Hello and welcome to tonight's Town Hall on AACPPR's COVID-19 response and considerations for resuming in-center cardiac and pulmonary rehabilitation services. My name is Molly Corbett and I am the AACPPR Senior Operations Manager, and I'll be serving as tonight's moderator. Just a quick housekeeping note before we get started. Throughout the presentation, please submit your questions for the panelists using the Q&A window on the webinar toolbar. We have allotted time to address them at the end of the presentation. Now it is my privilege to introduce AACPPR's President, Anna Mola.
Thank you, Molly. Welcome all. I am Anna Mola, the President of AACPPR. I am very excited about this new venue of communicating via a town hall to better connect with the AACPPR membership about current and emerging association initiatives. I would like to begin by introducing our distinguished panel of guests that have participated on the AACPPR COVID-19 task force the past 2+ months and have contributed to the document released last week, Considerations for Resuming In-Center CRPR Program Services. So can our panel guests please introduce yourself, name, where you work, role, and your AACPPR role?
Hi, I'm Kate Trainer, and I am the immediate past president of the AACPPR. I'm privileged to be here tonight speaking with you. I'm currently working in Boston at Mass General Hospital.
I'm Shelley McCabe. Oh.
Go ahead, Shelley.
So I'm Shelley McCabe. I work for Pulse Heart Institute, multi-care health system in Washington State. I'm the supervisor of our 4 cardiopulmonary rehab programs in the state. And I am the chair of the MARC committee for AACPPR, and I serve on the education committee as well.
I'm Gable Oakley. I'm the Director of Cardiology Services and Prevention at Boone County Health Center in Albion, Nebraska. I am currently the AACPPR Board Secretary and Editor of News and Views.
Hi, I'm Dean Deersing. I am the Assistant Director of Physical Medicine at University Medical Center in Lubbock, Texas. I'm the AACPPR President-elect.
Hi, Todd Brown, cardiologist at UAB. I was past president of AACPPR.
Thank you to our panel guests. So let me begin by stating that over the past several months, the COVID-19 pandemic has affected the healthcare industry on both macro and micro levels. Across the country, frontline healthcare workers and essential workers have continued to selflessly and safely manage this national health emergency. I would like to take a moment and acknowledge all those frontline healthcare workers, including those on this call, for your dedication and service during this unprecedented time. AACPPR has been laser focused and committed to address the challenges in how COVID-19 has affected CRPR program operations, finances, and the well-being of its members. Molly, next slide. I would like to briefly highlight the initiatives that AACPPR has created, advocated, and implemented during this COVID-19 national health emergency. As you can see from the slide, we first started by inviting and forming the AACPPR COVID-19 task force, which has consisted of AACPPR Board of Directors, established researchers, and distinguished clinicians, and our lobbyist GRQ. This task force has been an essential core team driving our association actions in response to COVID-19. Some of the activities have been to advocate to CMS virtual CRPR reimbursement during this national health emergency. AACPPR has demonstrated persistence in this important issue. Over the past 6 to 8 weeks, AACPPR, with multi-society support, have written and sent 2 letters to HHS Administrator Verma and CMS Coverage Analysis Group Director Cyrus Jensen. The CMS response to initial requests for telehealth waiver or codes that could be billed to provide CRPR during this pandemic was a no. The second letter that we sent on May 15th was framed to seek clarification on the use of telehealth reimbursement codes, site of service, and supervision for CRPR services not detailed or addressed in the first letter response from CMS. Additionally, in alignment with the advocacy requests of telehealth reimbursement, coming this summer, there will be an online learning module series on home-based delivery to complement the advocacy that we have had in the past 6 to 8 weeks. We're hoping, we haven't gotten a response yet, but we're hoping it will be a very positive one. And then we have just released considerations for resuming the in-center CRPR program services that was released to our membership last Thursday, and then will be the focus of this town hall. Next slide. So additionally, we also have created the COVID-19 Resource Center. This is basically a central hub for all relevant and current resources, communications, frequently asked questions, and video case studies that we identified within national case studies of CRPR program delivery transformations during this pandemic. And if you haven't seen these videos, they're quite educational, innovative, and creative. Next slide. We've also developed the COVID-19 conversation community, and this is a members-only platform for sharing best practices and asking questions and discussing top-of-the-mind specific CRPR program responses to COVID-19. And you can see the website there at the bottom of the slide. And if you haven't visited, I encourage you to visit it. So now we're going to be focusing on our considerations for reopening, returning with care. Hopefully you have come to the website to see this and downloaded the document. Next slide. At this time, I do want to thank the AACVPR writing group that primarily have been the members of the AACVPR COVID-19 task force. I want to thank them for their time during this very complex period of the pandemic. Our volunteers had to deal with personal families' well-being, supporting their local communities, being focused on their professional accountabilities and responsibilities to their employment at their hospitals and programs, and also still being focused on the well-being of our AACVPR nation. I also would like to express an endless thank you to our AACVPR staff that have been available early in the morning, late at night, and throughout the day to really have all these resources produced and available for our membership. So thank you, AACVPR staff. Next slide. So let's begin to review some of the highlights of the document of considerations for reopening. I just want to focus on some guiding principles. We had a lot of input from internal and external professionals. There has been a lot of evolving literature about COVID-19 care of patients, and also in terms of treatments, and also the delivery of various clinical services. And specifically to CRPR, we know patients are at high risk for complications of this infection. The safety and the risk of COVID-19 infection spread in a group exercise setting is basically unknown. So there is not a guiding research that we can focus on. So it's been pieces of other additional research and several hypotheses of what would be, safety in performing group exercise. Also, safe alternatives exist for appropriately selected patients through hybrid approaches. So we do want to endorse that if patients can come to the center-based programs, that there are hybrid approaches of virtual outreach for care for patients if your hospital programs are utilizing them. We also want to highlight that these considerations should be reviewed in collaboration with your infection prevention and control, IPC departments, medical directors in administration and regulatory, compliance, and legal team. And most importantly, this is a living document and will be updated as we learn more. Next slide. And for external factors, again, federal, state, local government, and hospital decisions and mandates should be the focus of programs' care of their patients in their local program. And also just to consider also the safety of public transportation use. So depending on the density of this virus regionally and locally, some mass transportations infrastructures have stated that patients need to use masks, well, not patients, but individuals need to use masks when they're utilizing public transportation. Again, this is local and regional, specific to the density of the exposure of the virus. But if your patients are coming in public transportation and they have been wearing masks, they should be utilizing a new mask when they come to the center. And I think that's been documented in our considerations as well. Next slide. And I think this time, Gayla Oakley is going to review this section on patient selection and risk stratification.
Thank you, Anna. One of the unique things about cardiac and pulmonary rehab programs is that we can individually design them to meet the needs of our patients. During this pandemic, we should be vigilant in knowing the guidelines in your region because what is prevalent in one area may not pertain to another. For example, here in Nebraska, I work in a critical access hospital with a 60-mile service area. We've tested quite a few and have only had 5 positive, 2 that do not live in our area. So we've not had any COVID hospitalized and are pretty low risk. But there are places in the same state that have hotspots and they are not able to operate like we do. Now tomorrow might be all changed. We could have an outbreak here and then we'd have to reevaluate. Patient selection for programs that have to be more creative in meeting safety requirements may need to focus on the patient with the greatest need and those who may derive the greatest potential benefit. So if you have 50 patients and you can only schedule 20, with the help of your medical director, you may need to review those patients and not enroll by diagnosis only. Regardless of which patient you enroll, all patients should undergo pre-program screening. This is determined by your facility protocol, but there is a screening checklist on the COVID resource page of the AACVPR web that you will find very helpful. Next page, please. Risk stratification might consider testing all patients before program entry and periodically, especially in regions with significant COVID cases and/or surges. High-density testing capabilities may not be available everywhere, but you will still want to screen all patients and consider the need to further limit patient capacity. The EMR is a great way to establish and monitor a patient's COVID status if it is accessible. Next slide. Last but not least, the staff considerations. Screen staff each workday. Some facilities screen everyone at the door, including employees, others screen that by department, but most facilities have their own protocol. Test if feasible and available based on your local IPC leaders, and any staff that develops symptoms or test positive will follow those facility protocols. Next slide.
Kate, I think you're going to be taking the infection prevention control section.
Yes, I'm sorry. I had to unmute myself. That would help. You know, this is a very important component of reopening. And, you know, just before we jumped on tonight, I had seen that the Wall Street Journal had published that there's over 100,000 deaths in the U.S. alone that are attributable to COVID-19. So we're talking about a highly contagious virus that, unless we're extremely careful and vigilant about spread and limiting transmission, we certainly don't want to contribute to any more of those kinds of fatalities. So the infection control prevention section is divided into three, as have been the other sections, with a focus on patients and what you need to think about in terms of working with patients and what patients need to be asked to do, staff considerations, and then in your program, some accommodations or changes that you may want to consider. And again, remember that, you know, the overarching principles and guiding strategies that both Gayla and Anna have already outlined for you, that this is a living document. It will change and be updated as we become more knowledgeable about, you know, exercise and the spread of droplets of the virus. This is going to vary by region. And so, you know, I know that you keep hearing that and probably wish that we would be far more specific than we're able to be, but because it does vary across the country in terms of the prevalence of the disease, it's hard to be that specific. But I think that you can take from each of these topics that we're touching on tonight what has the most pertinence for you in your practice and for your patients. So remember that safety of patients and reducing risk and spread of the infection is really paramount and takes precedence over everything. And that there are safe alternatives to in-center facility programs. And so, you know, we've talked a little bit about some of those hybrid or home-based efforts and approaches. So first and foremost, when it comes to patients, we need to make certain that they understand what would be asked of them if they come into facilities that are instituting practices and policies that require them to physically distance and use face masks. And the one thing that I want to say about face masks, the proper use of face masks mean it covers both nose and mouth. I can't tell you how many times I see people with face masks on that are just over their mouth. That droplets can be inhaled, obviously, and so covering face, covering nose and mouth is really essential. And frequent hand hygiene can't be stressed enough, and that's in any facility. Patients should understand the need to, both upon arrival, before getting onto the equipment, after getting off the equipment, before leaving the facility. There isn't any such thing as too much hand hygiene when it comes to COVID-19. The physical distancing, you know, you'll hear varying degrees or varying limits in terms of distancing. The minimum recommendation so far that we understand is 6 feet, but as patients begin to exercise and exert more effort and maybe aerosolize droplets, we may want to think about expanding that out. There's been some good data and some that suggests that patients that may be running and have some, particularly in an outdoor setting, have a wind stream created behind them, and that may, you know, carry the virus and spread the virus behind them to an extent. And also important, you know, for us as we're working face-to-face with patients about understanding the need to protect ourselves in that setting. If patients are asked to wear a mask, it's recommended that they change that mask when they arrive. First and foremost, bandana-like coverings are not as secure and as effective in preventing keeping the droplets in, which is the purpose of the mask that the patient's wearing. So giving them a new mask upon arrival will both be certain that you have given them a mask that will contain the virus or any potential spread of droplets, and at the same time be of good integrity, something that they've worn in. It's hard to know whether and how old that mask is and whether it's penetrating it or it is impenetrable as you'd want it to be. The other is that limiting the amount of articles that come in with the person are going to be important. You may need to think about policies around restricting use of locker rooms or showers, those kinds of things. And so cutting down on the amount of stuff that patients arrive with will certainly go a long way. There hasn't been any good data that suggests that there's transmission from clothing, but certainly anything that we can do to cut down on the possibility of that is really prudent and essential. I think the other thing that we want to do is reassure patients. I mean, one of the things that we're finding here in Boston is that even though we're beginning to open up, many patients are reluctant to come into the center. And so I think an important component of resuming practice is to assure patients what you're doing as far as practices that will both protect them, protect you, and cut down on their exposure when they do come into the facility. Next slide, please. In terms of the program, what's really important is going to be this physical distancing and spacing, not only you from the patient, but the patients from each other. So that means that if equipment can't be removed from your facility, that you, in some way mark off equipment that's not utilized so that you can assure that there's at least that 6 feet of distance between exercise equipment. The further apart, the better. I think that's certainly a good rule of thumb to work by. For patients exercising at a higher intensity, the further apart, the better. And that the equipment disinfection is essential. You should talk with your internal infection control and prevention resources. The hospital grade disinfectants are probably what all you need to use, but essentially need to allow for that dry time between patients and between use, so that you're absolutely certain that disinfectant is as useful and as effective as it needs to be. Next slide, please. So you can see in this aspect of the infection control segment, you can see the word limit all the way through this. And I think that the message in this limit is to certainly decrease the chances that we're going to cross-contaminate or spread. So decreasing the different types of exercise modes that patients use. Some of us have kind of a cycle type of training or moving from equipment to equipment. That may be something that you want to reconsider, because you've got to allow for disinfecting and dry time in between the change of those exercise modes. So this might be a practice that certainly you need to step back from and think through a little bit more effectively. Limiting class size is going to probably be a default because of the physical distancing. But again, there are some local municipalities that are limiting occupancy and capacity in individual practices and settings. So this may be something that's dictated to you and not something that you necessarily can choose yourself. And really limiting the amount of time that anybody's in the center or in the gym or exposed to you and other patients is probably an important consideration. So we're suggesting that the shortest duration, the most appropriate time to meet regulatory and billing requirements is probably what is rather prudent in this setting. And certainly limiting the frequency of attendance may be another way to mitigate and cut down on the risk of, too much exposure. And that supplementing that with, at-home activities or remote reach to patients may be a good strategy. Next slide, please. In working with patients, it's going to be important, again, to think about everything that surrounds them, whether it's a blood pressure cuff, an oxygen saturation monitor of some sort, that all of those things need to be disinfected in between patients, so that if you can dedicate those resources, use them only in the setting. You might want to think about best practices and whether, how often those blood pressures need to be taken, because moving those cuffs from one patient to another is going to require cleaning, dry time. And so, whether or not that's necessary is going to be a good question and a good practice for you to reconsider. Limiting the number of people in the space. So the no visitor or the patients only policy is not an option in some areas. I mean, that's actually a requirement, but it might be something that even if it isn't an option, or it is an option rather for you, you might want to rethink that. Cutting down on the number of people and the density of people in any one area is probably a good guiding principle to live by. And you might, as I said, you want to really think carefully about shared spaces, locker rooms, bathrooms, sinks, that there needs to be some protocol of consideration for cleaning in between use or in between sessions. And finally, limiting the amount of paper and the use of maybe some of the handouts or educational resources that you may be typically accustomed to using with patients may be something that you want to rethink, switching more to online or video type education, and using remote links and those kinds of opportunities at every chance that you get. Next slide, please. In terms of the staff, you know, none of us want any of our staff to get sick, and we don't want to get sick. So we want to make certain that our staff has the protective equipment to keep themselves safe, and that's going to include masks, gloves, face shields, goggles, whatever is prudent and necessary in your area. Again, we're going to be facing patients who could be aerosolizing droplets, and so we want to make certain that we're not inhaling those things and putting ourselves at any more risk. Physical distancing will be essential, and again, that principle of being, 6 feet minimally and maybe further if somebody's vigorously exercising at a higher intensity. And there's even been some consideration for physical barriers, transparent physical barriers, a plexiglass or some material of that nature to protect yourself, even with PPE, either between pieces of equipment or between you and the exercising patient. It's also important to think about other areas that your staff are going to come in contact with. So if you're sharing laptops, if you're for entering data, if you're sharing, office equipment, Xerox machines, I mean, any of those kinds of things, you have to institute some infection control practices and cleaning practices for some of those things in between use by your staff as well. And again, it's really important to think about when these masks come off, that's going to obviously expose the staff now face-to-face. So thinking about break rooms or lunch rooms and, whether or not you want to limit, the amount of people that are in those at any one time and then allow for the distancing between them if they're going to be eating lunch or taking breaks there. So thank you.
Thanks, Kate. So the section I'm going to run through is program operations. Is the last section that we'll run through. As you can see, one of the things that Kate kind of talked through, or most of the things Kate talked through, come to in the considerations of the program operations. You will likely, or we encourage you to consider starting with lower patient volumes. It'll allow you to maybe refine some of the things that you've implemented as part of your safety strategy and your cleaning strategy and protection strategy of staff and patients. So those the working through the wet times, cleaning, patient flow overall, it gives you time to adjust from that. I was talking to one of our leaders today, and she was going through some strategies with me, and she was talking about a patient that reached out and touched a set of weights, and she was like, no, not that one, don't touch it. So we kind of become a little bit of a, want them to stay away from stuff, don't touch it, because it's more cleaning we have to do, but giving yourself time to adapt to that, as some of the things Kate said. The next couple bullets kind of run together a little bit, but considering program scheduling and structure to accommodate patients and essentially accommodating smaller class times, smaller class sizes for social distancing. Some of the things that you may need to consider are staff cohort scheduling or scheduling some earlier morning sessions, some later evening sessions, splitting your staff up a little bit to where maybe some are working more in the earlier shifts and some are working in later shifts. Maybe you have to incorporate some weekends to be able to get the same volume in. But if you're not able to get your class size as large as what it was, you may have to look at strategies of staff scheduling and also smaller class sizes overall. Consider how to balance center-based versus home-based approaches. So looking at strategic populations, maybe you only bring back certain populations into your program if you have a limited capacity, working with your medical director, working with your physicians to determine what patients are our priority right now and who do we need to have in the center. Can you still maybe offer some of those home-based approaches to those patients you can't get into the center? Or do you need to look at strategic scheduling of maybe you only are able to do a month with this population and you discharge them into maybe a hybrid or a home-based model? So looking at those types of things to be strategic with your programming. Consider resources to address mental, behavioral, and emotional well-being. Within the document online, there's several resources linked directly to our reopening considerations. So we encourage you to go and look at those, visit those hyperlinks and look at some of the resources we have tagged in our document. And then as I think all health systems are experiencing right now, the financial impact and challenges of COVID, and really considering everything. Make sure you're staying in contact with your administration, looking at maybe being fully aware of the challenges, working with them for potential solutions and identifying those problems and solutions early, or working together strategically. Just kind of give you an example, we've developed a dashboard that we look at, and it's like a red and green report, a stoplight report that tells us, you know, how are we trending towards our strategy of maybe getting more staff in the door. So for example, if we have our staff reduced by 25%, we're able to look at this dashboard and be able to tell, hey, we're venturing towards 75% capacity. Is it now time to add more staffing in? Some of you have probably done this for a long time. It's kind of a flex staffing strategy, but really looking at maybe ways and sharing that with your team of ways that you can strategically be productive and financially viable within this time frame. Next slide. So at this point now we're going to turn it over to a couple of our panel presenters and let them share some of their experiences in the COVID and some of their reopening strategies. So we're going to start with a couple. If we have time, we'll go through a few more. The first one we'd like to share their story with us is Shelley. So I'll turn it over to Shelley.
So hi, thank you for having me here. This is quite a group. I'm excited to share. So we've, reopened our clinics about, gosh, it's been maybe a month ago. Started really light. We started 1 day a week. We opened our sites once a week with a couple staff. And I have 5 different sites, and we have to figure out how many patients per hour can they accommodate based on size and how many staff does that require. Each site has screening that's done. Some sites are in the hospital, so the screening is done at the door. I have one site that the staff have to do it themselves. So there's been some negotiation of how does that screening happen, who does the screening, and then how do they get handed off to the next staff person. One of the things that we've run into, our patients are pretty afraid. I know that's been questions on here as well. Patients are scared. They're scared to come back. So we've been really careful to outline what are we doing to keep them safe. So really looking at what is their barrier to return, what is their fear about? Is it about wearing the mask? Is it about getting sick? Are there other behavioral, emotional well-being issues that need to be addressed? And as Dean mentioned, there's a lot of resources for that we've included in the document. So I think one of the things to address those fears that we have done is really outlining our practices. We're pretty clear on what our safety practices are. And so we require, we limit our class duration, we limit how many times per week patients can attend. We limit those class sizes. We're not offering group education. We're practicing social distancing. Our patients are required to wear a mask. We train them very heavily on hand washing. So we have a handout. It's on everything, written everywhere. There's hand gel every 5 feet, I think, in every clinic. And so we are constantly cleaning the equipment. Staff also wear a mask. They do their own temperatures as well. And they're screened in the same manner as patients. So a lot of the fears are starting to subside. I noticed that there tends to be coincidence with what's going on in the state. So our state's pretty divided. We've got the Seattle side that's very heavily populated, and then our eastern side, which isn't as populated, and the rate of infection has gone in with that. So Seattle's been a lot higher. Spokane area has been a lot lower. So the return rate to clinic, we noticed as the state has opened up more in Spokane, the return rate has been, patients have been more eager to come back and less afraid. On the western side of our state, we're still fairly locked down. And so we're noticing that patients on this side are a bit more fearful. So we've done a good job with really outlining what our practices are and how we're cleaning, what's being required. We do give patients a mask if they come in without one. We had a group that made a bunch of masks locally, and so we have a huge supply that we can give to patients. So we're now looking at maybe coming in twice a week, but currently we're still just at once a week. Offering some home, looking at more of that hybrid approach versus just home or just rehab.
Very good, thank you, Shelley. Now we're going to turn it over to Dr. Todd Brown. He's going to share some of his story.
Yeah, thanks. So I think we're doing similar things what everybody else is doing. We reopened our cardiac rehab program about a week ago after having been closed for almost 2 months. We're doing it 5 days a week, but we've taken the approach of basically having more exercise time available. So we've taken sort of expanded the day, so to speak, so that there's more time for patients to come and fewer patients there at one time. So instead of having like 1 hour blocks of time for exercise sessions, we've been doing longer, like an hour and a half block of time to give us time to clean and that type of thing between sessions. And then only having 4 patients come in at most in any one session so that we can keep everybody 12 feet apart. I see there's a lot of questions in the chat about masks and exercising in masks and that kind of thing. Our approach has been, some of these patients are doing fairly low intensity exercise and can do that in a mask. Some patients are doing higher intensity stuff or are not comfortable wearing a mask. So it's sort of, if they can do it and wear a mask while they do it, we do that. If not, they don't wear the mask. But because of that, we have it set up so that they're all kind of really spread out in the gym so that everybody's at least 12 feet apart from each other at all times. And so that's why we're doing sort of no more than 4 patients at a time, and then really allowing people to come throughout the day. We've sort of expanded hours to have a lot of availability throughout the day to exercise. We don't have any group education because that's really hard to do in this environment. When people arrive, everybody that comes in our facility is getting screened at the door of the building, not necessarily of the gym. So you can't get into the hospital or get into the clinic buildings, et cetera, without going through an external screening process where their temperature is taken and they're asked questions about if they have any symptoms related to COVID-19. That has nothing to do with cardiac rehab. It's just anybody trying to get into the hospital or the clinic buildings have to go through that at the door. So they're all kind of evaluated already, but before they get to the gym. But it's important, I think, that you have some type of external screening process so that people with symptoms don't get too far in, so to speak. So they kind of go through that. They show up. They all have masks on. They're required to have masks to come in the building. And then if they can exercise with a mask, that's fine. If not, then they take it off. We have them really spread out. And then clean, obviously, as everybody's mentioned, cleaning is important, and cleaning between uses of equipment so that, and having appropriate dry time so that the next person can use it safely. I think everything else is fairly similar to what everybody else is doing.
Very good. Thank you, Dr. Brown. Next, we will turn it over to Gayla Oakley to share some of her experiences in Nebraska.
So as I mentioned before, we are pretty low risk. The state is really divided as to meat packing plants. Those areas are heavily positive. We are not. So we were closed only a few weeks, and that decision was made just to keep the people at home, not because of them not coming in, but we felt that if we gave them permission to come into cardiac rehab, then they thought they could go down to the big box store downtown and be okay. So we did close for a short time. We're open again. Our patients were absolutely ecstatic about coming back, and I think the providers were very anxious for us to start back also. And some of theirs is because this is a very rural area, and the isolation when you're in a rural areas, you are very isolated. So the providers were very concerned about their mental and emotional states, and they felt that coming back in was one good positive thing about that. So the patients have been real good. We only do 2 at a time. We're critical access, so there are advantages of being small. We're used to not very many in a room at a time. We have got everything distanced. Everybody has their own blood pressure cuffs, so we don't have to change them. And we provide more time in between for the cleaning. The equipment that we don't use, we have put sheets on. We've covered them up because we found that people tend to touch everything. So then we were cleaning things that we weren't really using to But all in all, it seems to be going well, but like I said before, that could all change in a heartbeat tomorrow. So.
Thank you, Gayla. Looks like we're going to have enough time. We're going to let Kate Trainer also share some of her story there in Massachusetts.
So, we're not far from New York and had some of the biggest challenge with COVID, and we're very slowly coming online. I mean, the governor has been very, very conservative about the reopening of the state, so that a lot of what I'm living with and what I'll need to consider in resuming operation is going to be dictated by, local municipality and governmental kinds of recommendations. The option of wearing or not wearing a mask is not an option. I mean, it's a requirement. And so, one of the questions that I saw that came in was, what if a patient refuses to wear a mask? They would not be allowed in our center. I mean, it's just not an option. So, and as far as exercising with masks, I think if you've never done it, I suggest that you try it and you'll know exactly what your patients are going to experience. We've been running in masks outside and exercising outside with masks in Boston for a little while. And I will tell you, it's not pleasant. It's not impossible, but it certainly does impact the intensity with which you can maintain your pace, frankly. So I think that will have, obviously some downstream implications for some of the exercise prescription intensity potentially. If people tend to be high-end or high-level exercisers. So we're rethinking literally everything from capacity to, we're accustomed to using charts when patients come in. The staff have gotten used to having sort of everything about that person together in one physical chart, and that really is not something that's recommended or going to be very well supported. So forcing people to rely completely on the EMR and the monitoring system is going to be a change in practice. The patients coming in small numbers, we're going to have to stagger our staffing. I mean, there's a whole reprogramming of how we approach our work. Our volume will be much less than we've ever experienced. We're resuming ambulatory at probably about a 20% capacity. And that's being dictated again by the state in terms of capacity limits and based on square footage and all. So, every one of these aspects of the program is going to be is being impacted and requires us to step back and rethink what we do. So I think that it's thinking out of the box, it's protecting yourself, it's protecting the patients, and really limiting the spread is really what it's all about, because I think that this will be pulled back quickly if we begin to see an increase in our numbers again.
And from a New York City experience as one of the epicenters and probably the highs with the COVID-19 death, wearing a mask is definitely a must. And we're actually wearing face shields as well. So we're going to the extreme because of the extremeness of our exposure to this virus. So very similar policies and procedures that everybody else has had. We are testing the patients for doing PCRs when they're going for their initial stress test. And also then screening just signs and symptoms and thermal checks when they come into the center. I don't know if anybody on this panel wants to address about the COVID-19 testing prior to start a program or during or before exercise testing.
So we talked about that at UAB and opted not to do it. Now, some of that's data driven in that there's actually two reasons why we chose not to do it. One is that we are doing for procedures, we're doing like cath lab, that kind of place. We're doing pre-procedure testing there. And the surgeons are doing it for all surgeries. Also, every patient who gets admitted to the hospital now is getting tested. So we have a pretty sizable database now of patients who were asymptomatic and were tested either because they were admitted to the hospital for something other than COVID or were coming for an operation or some kind of elective procedure and got tested. Our positive rates on those tests at asymptomatic patients is less than 1%. So because of that, when we talk with our infection control people, we decided that It's probably not necessary to test all of these patients that come in prior to starting. The other problem is that just because they test negative today doesn't mean they won't test positive tomorrow. When you're doing a serial, thing, how often do we keep testing them, And so we made the decision that because our institutional data suggested that the likelihood of a positive test in an asymptomatic patient in our population was low. Now, that may not be the case in New York or other places, so I think that's a local decision, but we have pretty good data from our facility that our likelihood of a positive test was low, and the fact that we wouldn't probably be able to serially test them anyway, that we decided it wasn't worth it. But we have taken the approach of just basically just treating everybody like they're radioactive and separating everybody out 12 feet so that, even though we're not testing them, we're sort of treating them like they're infected and just kind of keeping everybody spread apart. And the staff are not sitting there right next to the treadmill while people are exercising. We're trying to keep everybody sort of separated and doing as much from beyond 12 feet as possible. So I think this is a good time. We talked a lot in the R2R program a couple of years ago about like how necessary is telemetry, how necessary is it taking blood pressures while people are exercising. I think this is the time to really begin to think about every single thing you do that you've kind of always done, because that's the way you've always done it. People exercise at home all the time without checking their blood pressure every 30 seconds, so I think we need to revisit a lot of that. And we sort of push our staff to say, look, do you really need to get the blood pressure right, on every piece of equipment, every time, that kind of thing, to really keep people socially distanced.
Okay. I've had a lot of questions come in during the presentation. Are there any special HVAC or air quality standards to uphold for programs? Kate, I don't know if you want to take that one or anyone else on the panel.
So, that's a good question. And it's hard to be very specific or to, one size fits all. I mean, my thinking is that your public health or board of health agencies already have air exchange rates that are expected in patient care areas. And so that certainly increasing that air exchange rate, the use of air circulators, increasing exhaust out of the gyms. I mean, all of those things would be prudent. That's not to say that that's a requirement, but that certainly when you're thinking about how this virus is transmitted and how you can eradicate it quickly from the environment and improve the air quality is gonna serve you well. So I think certainly talking with your internal HVAC resources or engineers would be worthwhile in terms of making certain that you're at least meeting minimum air exchange recommendations, and then whether there's an opportunity for you to step that up a little bit or not without, I don't know what the expense would be for you, but I don't think that that's a bad consideration to have.
Thanks. Can you discuss if we need new orders for patients as well as new ITPs? Gayla, do you want to take that one?
Sure. If all of those regulatory questions are very well covered by Karen Louie on the COVID resource page. So if you go there, those kind of still are up in the air, and just as soon as we find out things, we put them on there. Also, your MAC people of your state and region are great resources for those questions too, because it does vary some by MAC.
Okay, great. We're getting a lot of questions about mask expectations, safety, tolerance, and who provides them. Does anyone on the panel want to speak to that?
So, I mean, I think I alluded to that a little bit. I think it really, again, it's very regional. We provide masks because they're required, and we are giving people fresh masks when they arrive. And, certainly there is going to be some impedance, and the higher the level of the exercise, the more challenging that becomes. But it is not an option here not to have a mask on. So I think that people understand that and are accustomed to it now. So it hasn't been a huge barrier or a turnoff for patients at this point, because they've just been wearing them now for months here.
And I'll speak from our program. In our facility, mask is strongly recommended. We aren't in a position where we can provide masks for our patients. And so with maybe some PPE limitations in areas with PPE shortfalls, maybe they don't have access to do that. And so we do encourage our patients to bring a mask, and it's strongly recommended that they use them. And as Kate said, making recommendations or being strategic with your programming of if it's a higher intensity, do you maybe need to pull that back if they're not tolerating it well, or other strategies around that. So just being strategic with your programming.
Okay. What are some legal ramifications of reopening that programs should consider?
So I think that's probably a local question, again, that you would need to discuss with your legal compliance and regulatory and medical director as well. I mean, depending on the density of the virus, it could, you know, I mean, in New York City, I can tell you patients are very, very concerned about coming back into a group setting. We have a major issue here in New York that patients are not, non-COVID patients don't want to go to the emergency room when they're having events, which has been an issue. So we thought our emergency rooms would be filled up once our COVID-19 admissions started to go down, but that's not the case. Emergency rooms are not full, at least in Midtown section of Manhattan here. So patients do not necessarily want to go back. What we are doing is increasing mental health services for them from the hospital, engaging LCSWs more, and having more access to some of our psychologists, because I think issues of generalized anxiety, agoraphobia, after being, you know, sheltered for over 12 weeks, and generalized depression is going to be a major concern. We've seen rates increase in domestic violence, substance misuse. So at least here in New York City, there's a lot, and we want to really emphasize that regardless of where in the nation, that there needs to be a really mental health perspective. But getting back to the legal ramifications of opening programs, I would advise, again, to discuss that with your local legal team.
Yeah, I think you got to know a little bit about what's going on in your locality, you know, external to the hospital too. And so, like, I know for us at UAB, we closed for 2 months, and we waited to reopen, quote unquote, until sort of the ambulatory environment was beginning to reopen. We never really like closed the clinic where no one was coming to clinic, but the clinic went through a phase where it was essentially, you know, it had to be really, really, really like, you know, urgent type of appointments that we would even allow people to come. And we would just, even for people who wanted to come to clinic for less than urgent stuff, we essentially told them we weren't going to see them, and it had to be telehealth. And then once we kind of started to relax those requirements and begin to allow more, you know, less urgent types of ambulatory visits is when we started looking to reopen our cardiac rehab program, and also time with when they began to relax some of the elective procedural restrictions. You know, so we went through about a 2-month period where no elective surgical or procedural type things occurred, and when that got relaxed, at the same time they relaxed some of the ambulatory rules, is when we began to open up. I wasn't planning on necessarily waiting for the governor to say anything about sort of non-healthcare related gyms like the YMCA, et cetera. It just so happened that they relaxed those requirements as well. And so when we didn't open up until actually the state allowed non-healthcare gyms like the Y to open up. That was kind of accidental. I wasn't really planning on waiting on that, but it just sort of happened anyway. But I think, you know, knowing those types of things, you know, are fitness centers and things like that open in your area? What are your ambulatory rules about clinic visits? What are your procedural rules, et cetera? You want to kind of be in line with what's going on there. And I think that's not going to be, you know, obviously universal throughout the country. So you just have to kind of know sort of what's happening in your institution from a healthcare perspective, and also your municipal area.
You know, Todd, you make a really good point on some of that. Just real quick, I think in our area, our clinics closed, our rehabs closed, not because of not being able to dial back like we're dialed back now. We could have continued that way before and had smaller class sizes and expanded to more days of the week and extended our hours. We actually closed for the 6 weeks because of PPE, because there was not enough PPE to go around the emergency stuff. And so clinics like ours didn't need to, because we are an elective, they canceled all elective procedures, including rehab. So it was less from a inability to dial back and more from a preservation of PPE. So I think moving back in is really looking at, okay, why did we close in the first place? And how can we reopen and get that message out to patients?
And then I think the other thing that kind of was stated, but to restate, is that these reopening guidelines these reopening considerations are just that. They're considerations. They're not guidelines. They're not standards. So we want you to review the document. It's on our AACVPR COVID page under returning to care. It's a 6-page document. We did a very high-level overview tonight. We feel like it's very important for you to go into that document, read through it in its entirety, work with your teams to get a strategy together for a safe environment for your patients and your staff.
I also want to state that Chris Garvey, one of the pulmonary rehab subject matter expert, was going to be on this panel, but unfortunately, at the last minute, she was not available. I think we've gotten a lot of pulmonary rehab questions through the Q&A and also the chat box. So we will have Chris Garvey review some of the questions and post them as well. So that should be coming in the next several days.
Great. Any final words from any of the panelists?
Well, I just want to reiterate again what Dean and others have stated, that this is a living document, high level, and we will constantly be monitoring changes, research that is investigated, and we will be updating this. We'll try to consider having additional more town halls to outreach to our membership. We think this is a good venue to really stay connected. We've been busy in the background. We wanted to come in the forefront here to discuss what we've done in the last 2+ months. So hopefully this has been helpful for all in terms of information. I know there's a lot of questions not answered, but they will evolve over time with more documented research to be able to share with our membership. I don't know if anybody else on the panel has any other final thoughts.
No, I'd just say that, please don't forget how important it is what you do for these patients. I think we all have stories about how our programs have impacted people even while we were closed. I know in our program, we have a couple of cases where staff just calling patients to check on them resulted in changes in outcomes and all. And I think, even for people, even if your patients aren't coming to the center, I think, your role in their, survival throughout this is absolutely critical. And stay engaged with your patients, both the ones that come to the center and the ones that can't come to the centers. I think you make a bigger difference in their care than you realize a lot of times. And let's not forget what we do well.
I think that's a great point, Todd. I think anybody that's probably got a remote outreach to patients has experienced some of that same kind of feedback from the patients, how appreciative they've been, especially if there's been a shelter in place or a stay-at-home order. People feeling very isolated and scared. The patients need you to help them get accurate information, have accurate information. The one thing that I would say, there's been an awful lot of questions tonight about reimbursement, for home-based programs or hybrid programs, and we don't have the answer for that yet. I mean, I think as we stated, we've reached out yet again through our channels to CMS and to the coverage and analysis group at CMS to try to help us understand where the exceptions will come in and whether there'll be some some consideration for, you know, helping us to utilize our typical codes and all, and whether they'll honor those with telehealth modifiers or what have you. So more to come on that, we hope. We don't know how quickly CMS will answer us. But I do think that begs the question about, and also if we're limiting capacity, I mean, I think this is going to be a very fiscally challenging time for programs. I don't think that we can deny that. So I think what would be helpful, and perhaps a suggestion that I might have, is to talk with your C-suite or your administrative leaders around what the expectations are of the program in terms of, you know, revenues and, you know, the impact on revenues and what will be tolerable, and, you know, just so that you can have some reassurance about the support that you'll continue to enjoy in this. And at the same time, you know, be very clear about the value of your service and what you've been able to do during this downtime if you've extended your reach remotely, to help them, as Todd mentioned, to understand what the impact has been on patients and on your ability to help them manage themselves at home and avert some potentially difficult medical challenges, which I'm sure many of you have done. So don't be shy about touting, you know, some of the good work that you've done and some of the reassurance that you've provided and the information that you've shared with patients to keep them safe. I think that's as important and valuable as is, you know, the finances.
And Kate, I want to dovetail off that. I think that some of you may have been at the conference in Florida several years back where Wayne Sotil gave the closing keynote, but he talked about the safe places that we create, the safe spaces that we create. And so the commitment that you've always had to this field, this industry, and your patients is obviously showing even tonight with the attendees that we have on this town hall. But continue to create those safe spaces, continue to communicate with your patients that they're in a space where you have created safety for them, and encourage them to continue to invest in their health. And so just wanted to kind of close with that, but thank you all for being here, and I'll turn it back over to Anna.
Well, just want to say thank you. Everyone be well and be safe, and hopefully we can have another town hall in the future to follow up this one. So thank you all for your attention, and stay safe. Thank you.
Thank you. Thanks everyone for participating in today's town hall, and I would like to extend a special thank you to our panelists for presenting. If we did not get to your question, please head over to the COVID-19 Conversations community to keep the discussion going there. Thank you again for attending, and have a great evening.